Hi guys, happy Monday. Thank you for joining me. My background is a little different today, mainly because I'm at home. I finished up with clinic in time and was able to come home and do the live from here. Funny thing, I just got internet at my house, seriously, like a month ago. So I couldn't have done this a month ago. Now it's nice. I can come home and talk to you guys from here. Thank you for joining me. For those of you from the PhD community that are joining us, thank you for being here. I start my lives a little different. I do some announcements and then I introduce the co-host that is going to be with me today. We're going to chat a few topics. I have some questions for her, and then you guys can post questions. So tonight's, just so you can start thinking of your questions, tonight's guest is from the gynecology world. Now, men doesn't mean just all of a sudden tune out and don't join us, but feel free to ask more feminine type questions, and everybody can learn from this because, guys, even though you are not female, you probably know a female and probably knows someone that this could impact. So I hope this conversation benefits everybody. All right, so on with the few announcements that I have. If you are in the Middle Tennessee area on August 5th, Dr. Barry and I are doing a free community live. There's around 20 seats left, maybe even only 15 seats left for that event. So if you want to the event, it is a ticketed event, but it is free. There's the website. Go sign up. It's only going to be about an hour and a half long, but it's just an open question and answer. I will be airing it live on my channels. So if you can't make it, you can log on and see it there. You can ask your questions, but we do take most of the questions from the audience. It's not a big frills event. There's not going to be vendors. There's not going to be anybody selling anything. It's just Dr. Barry and I offering free information to anyone who wants to hear it. So go sign up if you're going to be in the Middle Tennessee area. Like I said, we've got 15 slots left and then we're done. But the one you can come to is September 12th and 13th, Low Carb for Better Health. It's here in the Middle Tennessee area as well. It's at a beautiful state park, Montgomery Bell. This year, it's a full 2 days with exercise and vendor time in the morning, talks in the afternoon on Friday, a VIP dinner in the afternoon on Friday, and then Saturday is a full day of talks and fun, mingling with each other and mingling with the speakers. Don't wait, get your tickets now. And on that website, you can also find the links to the schedule. So you can see the full lineup of speakers. You can see the link to lodgings to go ahead and book your room. I do recommend staying at the park and don't wait on getting the reservations at the park because September in a state park will sell out and then you will not have anywhere to stay, or you'll have to stay like 30 minutes away because it is a rural area. So please go get your tickets and get your room now and join us for this fourth year of the event. I am so excited. I can't wait. Can't wait at all. All right. Lastly, you may have seen that I am now licensed in 23 states. We just added West Virginia. Woohoo! I'm so excited. So you West Virginia people, please give me a call and let's get you in and start working on your health together. I couldn't wait to partner with you. It would be my pleasure. So give us a call, or actually email is a little bit easier because my receptionist can get back to you quicker there. So it's just contact@clearpathmedical.net. All right, one more. My live times are changing to Mondays. I used to always do Tuesdays at 5:05, but it seems like life is changing and I'm on more on Mondays than I am on Tuesdays. So from now on, I will either be on at 5:05 on Mondays on my own channel. So for you Dr. Barry people, if you watch him at 6, you can see me ahead of time. I'm always done before then because I'm short-winded, but I'm going to be on at that time. And then sometimes I'm on with him at his channel, giving Nisha a break. And then I'm doing these every third Monday to help him while he is making Tennessee healthier again. And I really support his movement. Tennessee is a state that could use someone in its corner fighting for it and fighting for its health. So let's get on to our guest for today. So for today, Dr. Andrea Salcedo is a board-certified obstetric and gynecologist. She's also an assistant professor at Loma Linda University, and she is a leader in the metabolic health space for women. She has experience with it's a comprehensive clinical experience spanning from full scope OBGYN from routine care to complex things like endometriosis and PCOS and fibroids and abnormal bleeding, That's all within her scope of things that she specializes in. She integrates a root cause metabolic approach into her care. And that's something I truly admire, because the more I learn, it is that root cause and the metabolic errors and metabolism and just metabolic mess that we are that is the cause of most diseases that I'm finding. So Dr. Salcedo earned her DO and her MPH degrees. She completed her OBGYN residency at Loma Linda, where she is an assistant professor, and is board certified by the American Board of OBGYNs. She's an active clinical researcher. She serves as the principal or the co-investigator on multiple studies exploring insulin resistance, uterine health, and cardiovascular risk as they relate to gynecological diseases. She shares her experience through public education via her channel, Conscious Gynecology, so you can check her out there. She has a YouTube channel. She also practices telehealth in Florida and California, so if you need a gynecologist with a experience in those states. And she has spoken at several events, notably at Low Carb USA, which is the one that I got the privilege of hearing her speak at. So please help me welcome Dr. Salcedo.
Hey, it sounds tiring just hearing everything.
I know. I now have this alphabet soup behind my name. So it's like as soon as people start announcing me, they're like, really, do I have to say one more certification or degree or anything?
I'm so glad to be here. Thank you so much for just the invitation, and then just your interest in how women's health is very much modulated by all these insulin resistance things that we're trying to
Yes.
work through. So I appreciate the invitation.
Absolutely. And I'm going to go ahead and plug Low Carb for Better Health real quick, because Dr. Salcedo will be there speaking. You can meet her in person and ask her questions in between talks and hear her engaging talks. So another good reason to show up to that event. I'm probably going to say it like 15 times throughout this whole conversation, so you guys just hang with me on that one. All right. So I've got a couple of just topics that I want us to briefly talk about, and then we're going to take questions from our viewers that are online. So the first is, I have heard you speak, and you and I talked about it before on my show, as the uterus being an end organ. And that is probably something that doesn't, people are like, well, what does that even mean? Is it like the thing that makes us die in the end? I mean, what is it what does that mean? So kind of go into, what does it mean for the uterus to be an end organ?
Yeah, thanks. That's a really great place to start. So when we think about chronic medical disease and we think about risk factors that lead to diabetes and hypertension, once folks have those diagnoses, there's been many years before then where there is a lot of circulating inflammation that kind of starts to create changes, negative changes on our organs. And when we think about diabetes, at the end of the circulation of our entire body, there are the organs. So the whole reason for circulation is so that our body can bring oxygen and nutrients and things to the end of the circulation, the end organs. So these are like the solid organs, like the heart, the lungs, the kidneys, the the anything that your circulation is leading to. Now, for many years, our medical establishment has looked at cardiovascular disease as an effect of kind of like the organs that we have in common. So when you get diabetes, you get diabetic retinopathy. When you get, a diabetes, you're more risk for getting a heart attack. When you get diabetes, you're at risk of getting fatty liver. And so all of these things were looked at and under the lens of like organs that we have in common, right? And for men and women, when we look at that as a woman, how does the uterus receive inflammation? Because the uterus is also an organ that is receiving inflammation just like all those other organs are. And in fact, it's actually made of the same smooth muscle that our blood vessels are made of. And so whatever's happening in the blood vessels, think hardening of the artery, atherosclerotic disease, the uterus is receiving that same inflammation too. And so a big message that I want to share for doctors, but also patients, is that changes in gynecologic health really have to do with changes, similar changes that are happening in their other organs related to inflammation and insulin resistance that our body receives from all of those chronic medical conditions.
Hmm. Yeah. And man, I feel like it was probably just a couple of years ago in my career that I woke up to realize how much all of that is true. I knew that like PCOS went along with in organ and things that are like insulin resistance and that whole process, but I hadn't really thought of the uterus itself being affected, more than just the ovulation and the fertility side. So is is it fair to say that things like fibroids could be brought on from this metabolic condition? Like if the smooth muscle is growing abnormal, can that be just like the skin grows skin tags when it's got insulin resistance in other parts of the
Ab-
body? Is that?
Yes, yes, this is right. Yes. And so when we think about abnormal uterine bleeding, we think of PCOS, for example. When doctors and gynecologists and healthcare providers consider all the reasons why someone could have these gynecologic problems, period, menstrual problems, we actually think of it in two ways. Is this a hormone problem or is this a structural problem? Okay. And or it could be both, right? A hormone problem typically is kind of like the PCOS, irregular period, high insulin level that leads to blockage of the ovulation at the level of our brain through several pathways. But the structural problems still exist as well because the circulating inflammation molecules are going all around, causing the damage to the actual structure of the uterus and blood vessels too. And the uterus is just one big blood vessel. It's pliable, it stretches, but it also receives inflammation not only at the corpus of the uterus, which is the body of the uterus, but also within the lining of the uterus too. And so I've had many patients who have fibroids, or let's just say patients who have heavy or irregular menstrual cycles. We do an ultrasound and people sort of get like, oh, yeah, I have something wrong with my menstruation. I'm looking for a fibroid. Do I have fibroids or no? And it's like, no, you actually don't. And then patients and doctors even will scratch their head and say like, well, then what's wrong? Like, how come you're having this bleeding? Well, the lining of the uterus is something that you can't really see under like a microscope when you do an ultrasound. Okay, the lining of the uterus is a collection of blood vessels, just like the whole uterus would be as well. And so, just because you don't see fibroids in the lining of the uterus doesn't mean that those microscopic blood vessels at the lining of the uterus are impaired just as like all the other vessels are. And if they're impaired when the lining sloughs off, when you do have your menstrual cycle, the lining sloughs off. Usually that like the second day is mostly when people have like this heavy period. Well, those blood vessels, if they're functioning normally, should constrict and stop bleeding, okay, when they're exposed, but they don't. And so then that's why people have these long, heavy periods because those blood vessels are so impaired, they don't get the messages well enough, or they don't actually like constrict well enough because they're damaged. And if they're damaged, well, then the bleeding's just going to continue. And so the interesting thing is that a woman's menstrual, like the quantity of how much blood a woman should bleed during her menstrual cycle is actually equal to 60 cc's, which is two shot glasses. Okay, I can't think of like a better way to make that more practical, but like,
Most of
like
us understand that one.
right? Like, but that's like not that much blood, right? Like that's
Yeah.
like you got like, your kid's sick and you have the Tylenol like little cap thing, and you just give them a little thing of Tylenol, right? And so now we have like super ultra tampons, we have period underwear, like all this stuff, right? And it's not an accident that that's happening, right? The metabolic dysregulation is like has been going on and it's getting worse and worse and worse. We're doing more hysterectomies, and the more menstrual needs are happening. And so all these like the businesses are getting really excited about all this because all the things that they can sell, right, to help women through this really painful time in their lives. Well, I just kind of want to share the message that like women don't have to suffer silently about that, and there's like things that you can actually do, sometimes hard things, but to help with lifestyle changes that can help improve your menstrual cycle. So I forgot where we were going with that, but that's
We
yes,
were
the
good.
uterus can have and fibroids, yes,
Yeah.
um, fibroids are basically like atherosclerotic disease of the uterus. It's very, very interesting.
Yeah, I hadn't thought of a fibroid being that either. Usually I just, think of that as being in the heart, but there again, this is an end organ. And if you hear the thunder, it's because it's about to come like raining
Oh,
cats and dogs here at my house. But so I think one of the things while you're talking that stuck out to me the most, and it wasn't even something you said, but I think you can back me up on this, is that for years, traditional medicine has pretty much just tried to put a band-aid on these issues by, okay, well, you don't have a fibroid or everything looks okay, you might as well have some birth control, that should fix it. And that's kind of our band-aid. And not saying birth control can't help in those situations. I'm just saying we didn't address the underlying root cause. And it sounds like you're saying that we definitely need to be addressing that and stop just putting a band-aid on everything.
yeah. I think like we just have to teach our patients, right? Like we just have to share, this is what happened, this is how you got here. You've got lifestyle changes, you've got medications, and you've got surgery, like what sounds good, right? And so I think that like doctors and healthcare providers like recently, and gynecologists a lot right now, like we're kind of getting a bad rap because like a lot of the narrative out there is like, here's your medications and here's your surgery. And we've kind of forgotten like pathophysiology, right? And so I'm a big nerd when it comes to that. And I think like as healthcare leaders, like we should be able to distill and digest that information and give it to our patients so that they'll really understand what brought them there. And then they get to decide. The
Yeah.
thing is about like gynecology, like medications and surgery, like works pretty good, right? Like until it doesn't, right? And then patients just don't want that. I mean, I've had many folks who, you know, are like bleeding heavily. They're at the hospital getting blood transfusions, or I mean, that's like serious stuff, and so I have to be like, hey, listen, like let's treat you with certain medications. Let's do, blood transfusions or whatever. Let's do interventions, right, to get you healthy, and then we can talk all about like the lifestyle stuff. But I've also had patients who are like super on board, and it's like, unfortunately, like there's no data that says like all this like low carb and carnivore stuff can like make a fibroid shrink that's like 9 or 10 centimeters. Like there's just no data for that. I mean, I would love to do that study, but on the other hand, like this is so new, right? This is so new and exciting. Like the sky's the limit of what we can prove and show. And so I think that being said, we have to tell patients how they got there and give them the options. And so we've known this for a long time that PCOS like should be treated number one with lifestyle interventions first. The problem is that for decades, the messaging about what lifestyle intervention and what healthy diet is like been completely like false. And so then doctors were telling patients to like do a low fat diet and exercise and stuff. And unfortunately that didn't work. And patients came back and were frustrated. And then it was like, well, here's your birth control, and so that's okay. Like now we're in this new phase, right? And now I think there's a lot of interventions and room for growth here. So really the narrative is now should be like, how do we teach patients like, what disease processes really is? And then they get to decide. So.
Yeah. Yeah. I'm more on the weight management side of things. I'm not a gynecologist. And I see it very similar in my world is I need to teach you all of these things. I need to teach you the lifestyle, but sometimes you do have to use some supplements or some medicines just to help kind of get control of the
Yeah.
situation while you're fixing all the stuff, the underlying stuff that's there.
Yeah. Yeah.
Last time we talked a little bit about leaky gut and how leaky gut could relate to endometriosis or abnormal bleeding. Fill in the viewers about just kind of that idea that the gut is connected or can be connected to abnormalities in the uterine tract or menstrual tract.
Yes. So this is like one of my favorite things to talk about because it's a personal experience for me too, because I also had endometriosis and have, I guess, this tendency. And what endometriosis is where the cells of the lining of the uterus somehow escape the lining and start to implant in various spots of our body. The data is really interesting about where they implant. I mean, most of the time, well, these endometrial cells, the lining of the uterus, will implant in our intestines or on our ovaries and cause cysts. And And then those cells bleed when you have your menstrual cycle, and they basically receive the same signals to have bleeding episodes. And so they bleed in your pelvis, and it's really uncomfortable. It's very debilitating. 1 in 10 women have this, and it's a huge problem with chronic pelvic pain, and needing to use like elevated healthcare services, going to the hospital for emergency room visits for severe pelvic pain. So it's like a really big problem. It's one of the biggest reasons why people have hysterectomies. It's one of the biggest reasons why people don't work. And so, that being said, for many years in gynecology, we have been told about all these various theories about why endometriosis comes to me, because like they'll find it in like really weird places. Like they'll find endometrial cells like in our thorax, in our lungs, even in the brain and the eye and stuff. So there's all these really unusual theories about why it could be from maybe the lymphatic system.
Mhm.
It could be from something called coelomic metaplasia, when like the cells like just decide to change and they go along their germ cell layers. There's all these weird things. Well, by and large, the majority of the patients that have endometriosis seem to have this pain and implants of these cells within their pelvis and around kind of like their rectum and around like their bladder area and in the ovaries. Well, and then we've been kind of treating it like as if it were a gynecologic disease. And so, if ladies are having menstrual cycles that are causing a lot of pain, then if they don't want surgery, then using some sort of hormone method to lessen the bleeding is what doctors would do. So,
Mhm.
birth control again, these kinds of medications, and, anti-inflammatory medications, even medicines that help with blood clotting were all kind of the standard of care. And then eventually there was medicines that like shut down your cycle from your brain and induce a menopause and surgery. Well, a lot of these women who have endometriosis symptoms also have a lot of intestinal symptoms, bloating and constipation or diarrhea or pain at the back of the vagina upon intercourse, or pain with defecation, pain when they go number two on their menstrual cycle. Well, a, s- a clinical perspective and observation came out about 10 years ago in the American Journal of OBGYNs, which is one of like our big major journals, from a group in Europe, um, who said, could it be that the gut microbiome is actually the true culprit related to endometriosis? Now, the story came is that, could it be that if there is dysregulation within our intestinal microbiomes. And remember, our microbiome is like the collection of healthy bacteria in our intestines that works with our immune system to keep our immune system running as it should, and to be a major first point protector against external threats that our body takes in. Okay. So, like, think protection against food poisoning, think protection against allergy, all those things. If our gut microbiome is broken somehow, maybe from processed food, from smoking. There's even interesting data about trauma. Anything that breaks down that gut microbiome will allow breakage and leakage of inflammation from our intestines down, down, down with gravity, down, down, down into our uterine area and our the space between the rectum and the uterus. Well, then when that leakage goes down, there is an activation of inflammation. Like your immune cells in your pelvis and your peritoneal cavity are like, whoa, 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 what are these proteins doing here? What's this bacteria doing here? Like, this shouldn't be here. And so then your immune system activates and tries to process this. So it's already kind of a little hurt, a little tender as it is. Then you get your menstrual cycle. And this is why, from even the very first period, women have debilitating pelvic pain, is because when you get your menstrual cycle, the blood comes out of the vagina, but it also comes out through the fallopian tubes. Excuse me. And that is the key thing. The blood comes out through the fallopian tubes, and within that blood is cells from the lining of the uterus. Then those cells implant into those affected areas because the immune system has been activated. And because it's been activated, it creates new blood supply between those menstrual cells and your pelvic cavity. And then your menstrual cells are like, all right, this is our new home, and so then it starts to receive the same circulatory hormone signals as the lining of the uterus, and it tries to shed. And then, so when it bleeds in our pelvic cavity, it hurts tremendously. And then there's just nowhere for it to go. And so then it just kind of cycles. So that's why really one of my favorite things now, which is not most gynecologists, but like to treat, is the chronic pelvic pain related to endometriosis, because then we can teach patients about the gut microbiome disturbance and then treat the gut microbiome. And then once you do that, then your pelvic pain gets better as a baseline, but also on the menstrual cycle. A big vitamin that helps with this is what we're seeing is vitamin A. Vitamin A is an incredible prebiotic. So what's a prebiotic? Prebiotic is food for the microbiome, okay? And so it's like different from a probiotic. A probiotic is like what we take as capsules to supplement like our healthy bacteria, but a prebiotic is food for those healthy bacteria. And I'm not talking about the vitamin A that we get from carrots, because that's not the same. So the vitamin A that we get from organ meats, remember like when we were cavemen? Okay, when we were cavemen and we would sacrifice an animal, we would eat nose to tail, right? And so like everything would get consumed so that we can honor the sacrifice of the animal, right? Well, part of that was eating the organ meats, and the organ meats are actually a really high source of retinol palmitate, which is vitamin A. But then, so, our ancestors would eat vitamin A, and then that would be food for a healthy gut. And then we would have less pelvic pain and less of these problems. But because it's just not culturally acceptable to like eat liver anymore, right? Except for the French, they have it down because they still eat pate. It's actually pretty good. But we have kind of forgotten how our ancestors used to eat, right? And so, and it's not just like organ meat, like, oysters and eggs and, all these other things that are part of like a really good whole, animal-based diet is like really helpful. But like a lot of folks kind of forget that the vitamin A is like something really that your intestinal microbiome needs for, especially for women's health.
Yeah.
So that's endometriosis in a nutshell. And that's like kind of the new way that I'm treating, that the data supports. And if folks are looking for something a little bit different, by the time they get to me, they're so over it. They're so done with like taking, medications and surgery that, it's been a really helpful approach.
Yeah. Yeah. So my last question, and it ties into the questions that we're getting online, and I definitely want to get to those. It's just thinking more menopause. So there's that big study, the Women's Health Initiative study, and it scared everyone away from hormones. I remember I had just been out in practice not long when this study came out. It was like everybody had to be off hormones that day. So can you give us just a very brief synopsis of Women Health Initiative studies, maybe some good data that it gave us, maybe some bad data or misunderstood data that it gave us, and then we'll get to the questions.
Okay. So yeah, the Women's Health Initiative, which is the big major study that was published in about 2002, that looked at two arms, and it really looked at how women's risk for cardiovascular disease could be addressed with hormone replacement therapy at the time. And at this time, they were using synthetic hormones. Okay. And so there was one arm of women where they were using medroxyprogesterone acetate and ethinyl estradiol, which are estrogen and progesterone. And then there was one arm where a woman didn't have a uterus, because when you have your uterus, you need both of those hormones. And then the other arm was with women who didn't have their uterus, who were just given estradiol or ethinyl estradiol. And so the average age group for these women were about in their 60s and 70s. And so not typically among women who are first experiencing like their climacteric state or their menopause, premenopause symptoms of that. The menopause state usually lasts probably around 10 years, where you're like going through this process. And the average age of menopause is 51. And so the results of this study were really interesting, because they brought a lot of negative press to a lot of doctors and providers and patients who were using hormone replacement therapy pretty liberally for a lot of common major menopause complaints. This study ended up showing that there was a little higher risk of breast cancer in women who had the medroxyprogesterone acetate and ethinyl estradiol arm. There was a higher risk of heart attack and stroke. And then there was a higher risk of some other like colon cancers and things. And so um, it made everybody really scared. And so all of a sudden, overnight, people were getting phone calls to like stop their hormones. And it was, unfortunately, it was a little bit of a detriment to the community, especially among women, particularly because of just, this complete 180-degree, flip that we had. That being said, we've learned a lot from this study in terms of how does the synthetic hormones compare to what we have as something called bioidentical hormones, and it opened up a big movement among like naturopathic communities and doctors that were practicing with compounding pharmacies to start to prescribe bioidentical hormone therapy in ways that were not looped in with the FDA. Okay. And so that a lot of women got a lot of really great relief when they use compounding medications of estradiol, testosterone, and progesterone. The challenge is that every pharmacy, compounding pharmacy, kind of has like their own methods of how they do these things, and so the dosing was like very inconsistent. And a lot of folks who were using pellet therapies and stuff were getting super therapeutic doses of like hormones and stuff. And so it was starting to cause a lot of problems like masculinization features, and but also increasing someone's risk for heart attack, stroke, but also uterine cancer. And so it was a big challenge. But what I think when you think about best practices and what do you learn from, one extreme to the other is that now over the last 15, 20 years there has been a lot of FDA approved bioidentical hormone therapies that are very safe to use, but because of the shadow of the Women's Health Initiative, doctors and patients are reticent to use them. Okay. And so what is exciting about bioidentical hormone therapy that's within the FDA approval is that the risks for, that we saw in the Women's Health Initiative don't apply, okay, because they are bioidentical and we use them for very focused reasons. And so there are some reasons why some people shouldn't be on hormone therapy, people who've had a heart attack, a stroke, there's like, and it deserves like a really good conversation with the doctor or the healthcare provider, someone who's had hormone sensitive breast cancer, blood clotting risk, those kinds of things. By and large, though, they're actually very safe for folks that have chronic medical conditions and stuff. They come in patches, they come in suppositories, they come in capsules, and even sometimes creams. And so, and it's been showing a lot of really good benefit for women, and they're by and large very safe. So it deserves a really good heart-to-heart question with, and a counseling session with your healthcare provider to see if you're a really good candidate. And then the women that we're seeing that are benefiting strongly are the women who starting to use hormones right at their perimenopause and menopause state within those 10 years of their final menstrual period. And so unfortunately, that group is super different from the group of the Women's Health Initiative, because when you go through perimenopause and menopause, there is a restructuring of some of like our fat modeling that happens. So it like our fatty tissue starts to change from like being within our hips and then our thighs, and it moves towards our abdomen. Well, when it moves towards our abdomen, because of the declining estrogen of the perimenopausal state, that abdominal fat is way more inflammatory and increases your risk for insulin resistance. And so if you can start, and so then once it increases your risk for insulin resistance, you start having higher risk for cardiac issues and cardiovascular disease and all that. But if you can start hormone therapy a little earlier before that Women's Health Initiative group, within 10 years of that final menstrual period, we don't see the same risks that we were seeing within that group as well. So I think there's a lot of really great press going on right now. The FDA is trying to remove a lot of those negative black box warnings that come with basically every single hormone that that gets dispensed from the Women's Health Initiative. So they're really trying to rework that. And so I think it's a really great time to be in perimenopause because there's been such a move to help protect women and help promote health during that very difficult time.
Yeah, absolutely. Great synopsis. So let's move on to some questions. You ready? And
Yes.
to remind everybody that neither myself nor Dr. Salcedo are your providers. So this is general information, not direct medical advice. You still need to seek the care of your own provider. So this comes from Lynn. She's 60 years old. She's had a total hysterectomy in 2016. She had pellets from then to about 1.5 years ago. She's tired of the recovery from the pellets, the scars, the expense. She moved to a compounded estrogen testosterone bioidentical product. Her PCP is saying no need for progesterone. She has heard myself and Dr. Berry talk about the benefits of progesterone, even when you don't have a uterus, that there's other benefits. She is wondering, what are the benefits? Does she need progesterone? What are the benefits if she adds progesterone?
Yeah. So when I take care of patients like this, I think about a few different things. Um, the first is I feel like we should probably talk a little bit about pellet therapy. And I think this is such an interesting area. And I always try to come from a place of curiosity because in mainstream OBGYN culture and standards and guidelines, like pellet therapy is kind of like a big no-no. And so even like bringing it up, like people will all of a sudden like trigger and say, no, like that's terrible. And there's all these negative things. And so but I really want to know why, right? Like, why is it like such a big deal? And like, why are pellets like kind of looked at with disdain? And it's not because they're not FDA approved. Okay. So the reason is because a pellet, a hormone pellet, is actually a compressed hormone that is within it's it's just a compressed hormone using a stabilizer that is either put in your fatty tissue somewhere in your body, your legs or your arm or something, and it relies on the inflammatory response of your body to break it down and then disseminate it into your body. Okay, so it's not a polymer. It's not like the Nexplanon that goes in your arm. It's not like a continued slow release that it has been timed and studied. Okay, and as you know, everybody's inflammatory response is different. Okay, and so that being said, then sometimes with estrogen and testosterone pellets, it kind of can give some folks like a double dose therapy because the testosterone, if it's high enough, can convert into estrogen, and then you get even more estrogen. And with people with a uterus, that can increase their risk for uterine cancer. Okay, so that's like the big thing. And then like masculinization features and clitoromegaly, all these unusual things that can happen. And so that's the pellet issue. Like that's the thing. Now, going back to regular bioidentical hormone therapy, patches and capsules and things like that, when you don't have a uterus and you're using menopause hormone therapy for the treatment of hot flashes, patches are really great. And they actually work best with people who have a little higher risk for diabetes because they avoid the first pass metabolism or the liver processing. And so it reduces the inflammation, and it actually has been shown to almost obliterate the blood clot risk, which is actually pretty good. So when women don't have a uterus, patch estrogen therapy is like definitely the way to go. It's estradiol, it's what your body produces naturally. Now, the reason why you have to have progesterone with that when you have a uterus is because when you have extra estrogen without the stabilizing feature of the progesterone, it increases the risk for uterine cancer. That's really important. Okay. When you don't have a uterus, estrogen is really something that you can just kind of fly solo with for hot flashes and stuff. But there's all these soft symptoms too, that like insomnia or brain fog and joint pains and things, that estrogen can be very helpful. And so once you've kind of gone through the estrogen therapy, but you're still kind of getting a little bit of like these symptoms that are impeding your life. Progesterone therapy is actually very helpful to add, and it's very helpful with insomnia. And so, we often tell folks to take it at night before they go to bed and stuff, and that helps a lot. And so, really, it's just kind of trying to have a fine tuned precision medicine approach to who's in front of you. Now, testosterone is an interesting beast because the addition of testosterone really right now is FDA approved for hypoactive sexual desire disorder, which basically means like low libido. Um, and so we can give it in perimenopause and in menopause. The doses are 1/10 of the male dose, okay, and it comes in a gel, and it's actually really well tolerated, and people do pretty good on it. But there actually is no FDA approved testosterone formulation for women, and they're working on it. And so, but I think that when folks have used estrogen and progesterone and they still need the testosterone therapy to help with their libido, that's definitely a great way to go.
Yeah. Yeah. All right. So here's one I've never been asked on a live. Someone is asking for advice. She's had a UTI. She's prescribed antibiotics. She's worried about taking the antibiotics. I think in general, there's a fear of taking medications when you don't have to. She's just wondering, do you absolutely need an antibiotic to treat a UTI? What would you say to that?
Gosh, it depends. There's so much. There's so much there. You know, um, when I think about antibiotic therapy, and if patients have like a symptomatic bladder infection where there's a culture proven or nitrites in the urine that prove that there is like a bladder infection, you've got symptoms, like, then yeah, I think like sometimes you gotta treat. I mean, people died of infections, and so, but I also try to come from the spirit of like, how do we prevent this stuff, right? And this is like also like a fun thing because it talks about the microbiome. Well, when you're before you have your first period, okay? So if you think about a woman and her first period and like, prepubertal, the labia of the female genitals are just basically like two big labia. And like, there's like babies can use baby wipes and all this stuff. And there's like a roll for soap and stuff a little bit here and there to help clean. But as soon as you transition into a menstruating reproductive age woman, the role for soap actually becomes like a little bit more obsolete. And the reason is because the high estrogen levels start to change the tissue of the vulva and they become more foldy, okay? And that starts to attract there's the estrogen increases a molecule called glycogen, and the increase in glycogen in the private area starts to attract a special kind of normal, healthy vaginal microbiome bacteria called lactobacillus. And then lactobacillus secretes hydrogen peroxide, which like kills off all the germs. Okay. And so it's not an accident that God put your rectum, your vagina, and like your urethra, like all in the same track. Like, and so, but a lot of folks feel a lot of shame about that. Like, does it smell? Like, do I need to use like female, feminine hygiene products and wipes and all this stuff? And like, don't even get me started on like the like pubic hair, right? And so, God, God, like, evolution and God or whoever you believe in, like, did that on purpose. Okay. And so the reason is because all of those things like pubic hair and the structure of our private area lends to support a healthy vulvar vaginal bacterial environment that prevents bladder infections. Okay. And so when women start to over clean or are shaving off or waxing off all their pubic hair, it tends to lend to less of that healthy bacteria and allows like E. coli and bladder infection causing agents to go up into the urethra. And so I always feel bad because like a lot of young women tend to be on like preventive antibiotic like before they have sex and things. They'll take an antibiotic and stuff, and it's like, dang, like I don't know if we really need to do that. And I think like it's just really more teaching women about the physiology and what's normal in their body. And then the big reason why ladies in perimenopause and menopause start to get more bladder infections is because there's declining estrogen and declining lactobacillus. And so just really promoting like a healthy vulvar environment is like really important. So to get back to the UTI question, that's a hard question. You have to have that discussion with your doctor. But in the spirit of prevention, that's usually what I teach people in terms of prevention.
Yeah, love it. All right, let's flip to the opposite end of the spectrum. Best advice for someone in their late 30s still wanting to have children, but it hasn't happened yet. And I think this is one that kind of tugs at our heart, kind of thing. So what just general advice can you give for someone wanting to conceive and they're in their late 30s?
Yes, thank you for the question. It's a really good question because women in their late 30s are still women of reproductive age, okay? And so if you're still having your period every month, you could still get pregnant all the way up until that final menstrual cycle. And so, what's the best piece of advice that we can give to women in that age group? Really, keep your insulin levels low, follow a low carb, high fat diet, really be, lift up yourself with, promoting the introduction of healthy fats into your diet because fat is the building block for all your hormones. So if you don't eat fat, your body's going to be in crisis. And so that's like really important. But also like to allow yourself the addition of a little bit of healthy carbohydrates, I'm not saying to go binge it out or anything, but particularly during that week before your menstrual cycle, because that week before your menstrual cycle is the week that your body's expecting to be pregnant. And so that being said, like, it's not a good idea to try to be like super carnivore during that week or zero carbs because your body actually does rely on a little bit of carbohydrates to share with your brain that you're actually healthy enough to conceive, but also to have like a healthy post ovulatory pattern that will help support a robust ovulation. And so I have a lot of patients that are tend to lean carnivore, and so they've done it for a couple years, and then all of a sudden they're starting to have menstrual abnormalities, and that's because like and I think being carnivore is a really great thing, but we have to kind of do it in the way that respects like the intricacies of a woman's body, and that's really important. As that like women really have to kind of eat in line with their cycle and have an understanding of what that is and what the best nutrition is during the week or so before your period, which is called luteal phase. And so having a little bit more carbs during luteal phase will help support a healthy ovulation. And so, really, and just like having a healthy lifestyle, exercising for muscle building is really important. That's like why my hair is wet right now because I went to go exercise before I started this, and so really trying to carve in time to, create like a balanced lifestyle is really important.
Yeah, absolutely. And let's just clarify, when you're saying healthy carbs, you're not saying just because you crave chocolate, you go have chocolate that week. I'm assuming
That's right.
you're
Yeah.
very
Yeah. And
low starch
you know
veggies and things like that.
yeah, and it's like, the thing is that don't you wonder why we crave carbs
Um,
during that week, right? Like, so I'm very much into like, what's the biologic adaptation? Like, why did our bodies evolve for this particular tendency? Okay, the problem is in modern culture we just have so much access to carbs that it just like we kind of overshoot. But that craving for a little bit of chocolate or whatever, during that week, like have a little square of dark chocolate, go for it, like and so but just do it with intention and understanding rather than spontaneity.
yeah, yeah. So what I just heard is it's okay to give myself a reward for being a female that time and have my square of dark chocolate and don't feel bad
An
about
intentional reward. Yes,
it. An
yes.
intentional, small, measured reward. All right. So Tierney says, can starting HRT cause major carb cravings, hair loss, and weight gain? Last year, she really messed up my carnivore progress, and she's been unable to recover. She quit HRT until a month ago. So I'm just putting pieces together that possibly she started HRT, started all these cravings, went off the wagon, and so now she's just wanting to know if they can be related.
Yes, it can be because particularly because of progesterone.
Mm,
Progesterone's the body. Think of the word progesterone, right? So progestation, okay? So progesterone, when you're on that, yeah, it's going to definitely increase like your cravings and like your interest in eating a little bit more because you're when you introduce that hormone, your body is kind of preparing for gestation. And so a little bit of extra, food intake is not uncommon during that time. Yeah, hair loss. I mean, hair loss is one of those things that, man, like there's so many things that can cause hair loss. And so, I think of like, what is that called? Telogen effluvium or something, where it's like basically like you are losing hair, but really like the big reason why it happened like 3 months before. So it's like, what happened 3 months ago? I don't know. And so that's like a hard one. With the hair loss, so many things can cause that, but definitely the weight gain from progesterone for sure. And it doesn't mean that it's like, you know, like don't do it, right? You just have to understand why that is and kind of monitor your eating progress. But that's why a lot of folks that on synthetic hormones like Depo-Provera shot, birth control pills tend to gain weight because it actually does increase your appetite.
Yeah, absolutely. So some of the viewers had questions about, they heard you mention the uterine hyperplasia, wanting to know what do you recommend to prevent uterine hyperplasia? I'm also assuming in the context of hormone replacement.
Yeah, so uterine hyperplasia could be a fancy word for thickening of the lining of the uterus. Thank you, Steve, for your question. And that context, a lot of the recommendations can be applied to many different phases of life. So, a thickened lining of the uterus during reproductive age doesn't necessarily mean a whole lot as long as you're having a normal regular cycle. But if you have a thickened lining of the uterus without a normal regular cycle, it does slightly increase the risk for uterine cancer. And so, estrone is the hormone of estrogen that comes from your peripheral fatty tissue that can also stimulate, it's a type of estrogen. It can also stimulate the lining of the uterus to grow. And so that is also what increases the risk for uterine cancer. And it also helps with like actually blocking the ovulation as well. So then you just keep growing, 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 and you get a lot of this extra estrogen and it increases that. So that's like in a reproductive age woman. And then in a menopause phase woman, if you, both of these problems are kind of at the same root, which is basically you need to add progesterone to help with that thickening because it stops the thickening of the lining of the uterus. So, in menopause hormone therapy and in reproductive age women, you really do need progesterone in some form, either biologically or from hormone replacement therapy.
Yeah. Awesome. So we had a few questions that were non-gynecological in nature. I don't know if you feel up for those, or I can always go in and find
Yeah, let's see, let's see.
All right, so here's one. Hello from Virginia. She had a CT scan to get a calcium score, so she's looking at her heart health. Other results, she had a 9 millimeter nodule in her left lower lung. She has a follow-up CT in 3 months. What would you suggest, if anything, until then? I mean, I know what I
Oh
would suggest.
man. Yeah, that's a tough one. That sounds like a really good conversation with family medicine, primary care, to really, there's so many things there.
Yeah.
I'm sorry that you got that. You were probably going from the spirit of trying to get your CAC score, and then all of a sudden you found this incidentaloma, we call them. Incidentally, we found this little thing. And so there's a lot of things that can cause those things, and sometimes scarring and stuff from like maybe a pneumonia that people had, or just like unstable nodule. Hard to say, but I agree with the follow up. That's really important.
Yeah, absolutely. I agree with the follow-up. And I would say is don't panic. Don't panic
Yeah.
yet. Have your follow-up. Try not to worry about it. They're doing their due diligence to make sure that it's not going to grow. So, just don't panic. Take it a day at a time. A lot of people are asking what states that I'm licensed in now. I just post that on my Facebook. So you can find me at Decker Less Carbs at all of my channels. And it's got an updated list with all 23 states. So you can check it out then. So why don't you take this last kind of little bit? Well, maybe we might get another question, but take a moment and give us a sneak peek at what you might be talking about at Low Carb for Better Health.
Yeah, I was going to ask you, there's so many things that we could talk about. And, I think just promoting the idea that the uterus is an end organ, I really think is a really great start, and kind of seeing where the conversation would go to. But yeah, I mean, there's so many things that are applicable to women's health in general. And so I'm happy to take any suggestions and stuff. I actually haven't written the presentation yet. I was going to reach out to you, like, what are we going to talk about? But
Yeah, and I would say menopause is a huge topic. We always get a lot of questions every time I'm on live.
menopause would be great. Yeah.
A lot of menopausal questions. I love the idea of the endometriosis and the leaky gut. That just fascinates me as well. I think that's
Yeah.
super interesting. But another one we do get asked about, which we got the question here, was, fertility. How do we prepare our bodies for great fertility? What does that look like? Because you're a mom before you're a mom, getting your body ready for all of that. So I don't think there's a way you can go wrong, but I definitely think menopause is the most hot topic that we get asked about the most.
Yeah, I think we should, especially because there's like a lot of changes at the FDA level that, that we're trying to move to and stuff. So yeah, I think that would be great. There's a lot here. It sounds like we got any good positive topics from what we've talked about we can expand on. So
Yeah, absolutely. So we had another one come in. It's I'm in perimenopause and she's on bioidentical hormone replacement therapy. She had an out of nowhere weight gain in the last 8 months. She does eat a keto slash carnivore diet. Is there any hope for losing this extra weight? She's struggling. I bet you this is something that you've.
yeah, that happens a lot. Unfortunately, and I feel like women in this phase tend to gain about 10 pounds, plus or minus if you right around their midsection. And yes, we see that sometimes that happens from perimenopause, and those structural changes from the fatty tissue from your hips and thighs into your abdomen. That just has to do with declining estrogen levels. Sometimes other things that are kind of like the insulin resistance effect of being a hardcore carnivore in women can sometimes lead to that when they're more of a protein leaning on carnivore diet. And so sometimes, particularly slender people, I'm starting to notice where they start to get more of when their body has basically exhausted a lot of the protein that they're consuming, and then the protein turns into glucose, and then we start to see like an insulin resistant phase just from that. And so then we see that as like high normal liver enzymes. And so that can be a big root cause of like why someone in the perimenopause phase could have this extra weight gain too, particularly if she was like doing some fasting as well. And so I know that happens sometimes even automatically, because when you eat such a great healthy high fat diet, like then you don't really feel that hungry, and so then but that can actually be sometimes a little bit of a strain in the system, particularly in the luteal phase, the phase right after ovulation. And so, where we were talking about earlier, to introduce a little bit of healthy carbohydrates during that time makes sense, because I try not to go from a one size fits all approach, particularly with women who are on carnivore, because of that potential insulin resistant effects from protein.
Yeah. So the only thing I would add, and I bet you would agree with this too, is it may not be hormone at all.
Mm-hmm.
Sex
Mm-hmm.
hormone at all. So perimenopause, I am in my mid 40s. It's a pretty stressful time. I've got
Mm-hmm.
this career going that I'm building. I'm still raising children. I have ailing family members that are aging. We got a lot of things pulling us in multiple different directions. And what I've found for myself is the things that I used to do to help kind of manage my weight sometimes aren't as effective. And especially when it comes to my stress management, to making sure I have a good bedtime sleep routine and all of
Mm-hmm.
those, if I let loose for a minute and stop paying attention to my self-care and that stress management, the weight gain comes. And so a lot of times you do
Right.
have to really focus on those things outside your hormones. It can be your hormones, most definitely,
Mm-hmm.
but it can also just be all the other stuff that hits us in that
Right.
perimenopause phase time.
Yeah. Sleep is a big one. Sleep is a real big one. So yeah.
Yeah, absolutely. All right. I think we got a little bit more. Does carnivore help with postmenopausal hot flashes and headaches?
Yes, a low carb diet in general can help with that, because lower insulin levels will change the signaling at the brain that leads to what we call vasomotor symptoms. And
Mhm.
so, the lower your insulin level is, and the less inflammation that you have from your fatty tissue that gets released, less of that signal of the thermoregulatory system that leads to hot flashes will be set off. And so that's why a lot of folks that struggle with metabolic syndrome, obesity, that kind of stuff tend to have a lot more hot flashes during that phase. So, low carb dieting, ketogenic diet, carnivore can help.
Yeah. Have you seen women in their late 40s, early 50s who thought they were menopausal, that all of a sudden, once they go on a carb restricted diet, they're not really menopause, they're not in menopause yet, or they haven't reached that threshold yet?
Yes, I've had many women in their 40s come to me and were told that they were in early menopause because their period stopped. And they were actually PCOS and ovulatory, no ovulation because their insulin level was so high, and
Mhm.
so then yeah, you start them on some sort of animal-based diet, and then they all of a sudden start menstruating again, and it's kind of funny because they thought they were out of that phase, and
Uh-huh.
so yeah, that happens a lot.
Yeah.
Even pregnancy, right? Pregnancy.
And that's typical. Well, I was going to say it's typically a happy thing, but it may not be a happy, or this might be a
It
surprise
it
thing.
may be a surprise, yeah,
In your
yeah,
late 40s and thinking you were done with that, you were over, and all of a sudden, surprise, here we
that's
are.
right.
Awesome. All right. Thank you so much for joining me. Let's remind everybody about Low Carb for Better Health. Please go and get your tickets and meet Andrea and I in person. And we can't wait to see you there. You've got a couple of weeks, well, actually about 2 months left to buy tickets before they close down. It will close down a little closer to time. If you have other questions, comments, things you would like me to address in future times that I am filling in for Dr. Berry, please list it. Thank you for your time tonight. Have a great one.
Thank you. Have a good one, everyone. Thanks for coming.